A very good evening to all my wonderful students. This is Dr. Gayatri, Professor ENT, trying to make ENT sound logical and easy for undergraduates. Today, we discuss one of the salient topics frequently questioned in the clinical examination, chronic otitis media. And today's question of interest is differences between chronic otitis media types, basically the mucosal and squamosal types. So let's begin. What are the types of chronic otitis media? As per the new classification, we have broadly mucosal and squamosal disease, which are further classified into subtypes. Mucosal disease is classified into inactive, active, and healed stages. Squamosal disease is further classified into inactive and active stages. Inactive mucosal disease is characterized by a dry permanent perforation. Active mucosal disease is characterized by active discharge, either mucoid or mucopurulent discharge, along with evidence of congestion of the remnant tympanic membrane, congestion and edema of the middle mucosa, which may even turn polypoidal. Healed stage of chronic otitis media mucosal disease is characterized by healed perforation, tympanosclerosis, adhesions between the tympanic membrane and the middle layer, granulations within the middle layer. Squamosal type of chronic otitis media can be again classified into inactive and active types. Inactive stage is represented by a retraction pocket, which is commonly found either in posterior superior part of pars tensa or in the pars flaccida. Active squamosal type is characterized by the hallmark of cholesteatoma. The other terminologies commonly used in place of squamosal and mucosal type of CSOM include unsafe, unsafe, atticoantral disease, and tubotympanic disease. Safe and tubotympanic being the other names for mucosal, unsafe and atticoantral disease being the other terms commonly used for squamosal. How do we distinguish between these two entities based on the nature of the ear discharge? So first let's know the fact, subsequently let's try to reason it out as to why it's like that. The nature of the ear discharge in mucosal type is profuse, mucoid or mucopurulent, non-foul smelling, non-blood stained, aggravating during attacks of cold or water entering the ear, and relieved on taking medication, either in the form of topical ear drops or in the form of systemic medication. Squamosal type, on the other hand, is characterized by scanty, foul-smelling, purulent, and occasionally blood-stained discharge. Now let's see why this is so. First, we will reason out one by one. Why is mucosal disease, discharge in mucosal disease profuse? Discharge in mucosal disease is profuse because it involves the mesotympanum, the hypotympanum, and the protympanum, which are lined by columnar ciliated epithelium containing plenty of goblet cells and mucus secreting glands. Hence, the discharge in case of tubotympanic disease, which involves the anteroinferior part of middle ear cleft, is profuse. On the other hand, in articuloantral disease, the site involved in the middle ear cleft is the posterior section, which is lined by flat pavement type of epithelium. This flat pavement type of epithelium lacks mucus secreting glands and goblet cells, and hence the discharge in case of squamosal type is scanty, unlike in mucosal type. The next statement that we saw is regarding the characteristic of ear discharge. In case of mucosal disease, we saw that it was mucoid or mucopurulent, whereas it was purulent in case of squamosal disease. Again, because of the same reason, that is, lack of mucus secreting glands in attic leads the discharge to be purulent, unlike the case with mucosal disease. The discharge is non-foul smelling in case of mucosal disease and non-blood stained, whereas in case of squamosal disease, it is foul smelling and occasionally blood stained. Why is it foul smelling? Because the cholesteatoma has the capacity to cause bone erosion, and the osteitis and bone erosion is the cause for the foul smelling discharge. Granulations are usually present adjacent to the site of bone erosion, which, when meddled by the patient, may lead to occasionally bloody discharge. So, this summarizes the reason behind the nature of discharge seen in tubotympanic disease versus that in adipoantral disease. The type of perforation in case of mucosal type is a central perforation that because it involves a pars tensa. So a central perforation is a perforation that's confined to pars tensa that's surrounded all around by remnants of pars tensa. A marginal or attic perforation is seen in squamosal type of CSOM. Marginal type of perforation involves the pars tensa again, but then at least one of the margins is formed by the bony sulcus tympanicus and the fibrous annulus is absent, because of which the epithelium from the exlanotary canal, the skin, can migrate into the middle ear, leading to the formation of cholesteatoma. Hence, it's an unsafe type of perforation. The same thing even with the attic. In the pars flaccida lacks annulus and it's directly attached to the scutum. Hence, any disease out there can easily spread into the middle ear and epithelium can invade into the middle ear. The type of polyp seen in tubotympanic disease is pale, pink, edematous, and doesn't bleed on touch. Whereas that seen in squamosal type is reddish, fleshy, granular, and bleeds on touch. Why is this? Because the polyp seen in mucosal disease is a true polyp. It is a protrusion of the edematous hypertrophied middle mucosa through the central perforation, and it's lined by middle mucosa. Hence, it does not bleed on touch. On the other hand, in squamosal type, the structure that appears like the polyp is actually a granulation and which is raw and hence it bleeds on touch. The granulation is usually seen adjacent to the site of the osteitis. The cholesteatoma is a characteristic feature of aticoantral disease or squamous type of CSOM, and retraction pockets are their precursors. The risk of complications is higher in squamosal disease than mucosal type. Why is this? There is crowding of structures in the attic and there is poor ventilation in the attic. If you see the second picture in the slide, you can see that there is crowding of structures in the attic with the ossicles and plenty of mucosal folds surrounding the ossicles. If you see the first picture, you can see a cut section of the ossicles and at the level of the attic. Here we can see the mucosal folds surrounding the ossicles all around, leaving just two tiny pores called as anterior and posterior tympanic isthmi through which the attic gets ventilated from the mesotympanum. Hence, the attic is extremely poorly ventilated and can easily get blocked because of inflammation from it can be separated thoroughly from the rest of the middle ear and there's high chance of negative pressure created within the attic and this is compounded by the crowding of the structures in the attic. And why is it causing more complications? Because there is, in addition to this, there's presence of vital structures in attic like ossicles. You have the facial nerve, the lateral semicircular canal, all of them coming in close relation to the attic, which can get damaged. The flat pavement-like epithelium lacks mucus-secreting glands in attic, and hence the inflammatory secretions do not get cleared easily. and this leads to progression of disease faster. Coming on to hearing loss, mucosal type is characterized by mild to moderate conductive hearing loss, whereas in squamosal type there can be a variable presentation. In fact, some patients with cholesteatoma may have even normal hearing, and this is because of the bridging effect of the cholesteatoma. The cholesteatoma matrix bridging the gap between the eroded ossicles and conducting the sound, which can will be absent after the removal of the cholesteatoma during the surgery and can lead to reduced hearing of the patient after the surgery when compared to that before the surgery. So these kind of patients are called cholesteatoma hearers, and they need to be counseled regarding the possibility of worsening of hearing following the surgery. The hearing loss degree depends on the degree of ossicular erosion in case of long-standing mucosal type. So the most common ossicle to get damaged is the long process of incus, especially the lenticular process because of precarious blood supply. Next to that would be the stapes suprastructure, and the last one would be the handle of malleus. So tympanic membrane perforation alone may cause less hearing loss, whereas the tympanic membrane perforation with ossicular erosion may cause more hearing loss. To summarize, the differences between tubotympanic and anticontrol disease. Discharge in case of tubotympanic disease or mucosal type of chronic otitis media is profuse, mucoid, and odorless and non-blood stained, whereas that in squamosal type is scanty, purulent, foul-smelling, and occasionally blood-stained. Perforation in tubotympanic disease is central, where that in squamosal is attic or marginal. Granulations are more common in aticoantral disease, and cholesteatoma is the hallmark of aticoantral disease being in active stage. Polyp, the classical polyp, pale pink polyp is seen in tubotympanic disease, and usually what we see in case of aticoantral disease mimicking a polyp is a granulation. Complications are more common in aticoantral disease and rare in case of tubotympanic disease. Audiogram shows mild to moderate conductive deafness in case of tubotympanic disease and a variable presentation in aticoantral disease. Thank you for patient listening. Keep listening to the channel to get more interactive videos. Thank you.